Welcome to our ERC virtual Meet the Expert session, where I am pleased to host Jerry Nolan, who is a chair of ERC and editor-in-chief of Resuscitation Journal. Welcome, Jerry. Dear Jerry, what are the likely causes and outcomes for cardiac arrest in patients with COVID-19?
Well, I think this is obviously an unusual situation. We have a disease which is principally, we think, respiratory, although obviously it can involve most other organs as well. At the moment, we have, I guess, just one main report on cardiac arrests in patients who have COVID-19. And this is a report that's just been published in Resuscitation. It's a report from Wuhan in China, obviously, which was really the epicenter at the start of all this pandemic. And they've reported on a total of 136 patients with COVID-19 pneumonia. So they specify that these are obviously quite sick patients in hospital, 136 cardiac arrests. In their series, most of those cardiac arrests, interestingly, occurred on the wards. In fact, over 80% occurred on the wards. And not surprisingly, the primary cause of cardiac arrest in a patient with COVID-19 is hypoxemia. And I think in their series, something like 85% approximately were of respiratory cause. And I think they cited something like 7% that were of cardiac cause. So although the majority seem to be hypoxemia secondary to the pneumonia, we do know that you can have cardiac involvement with COVID-19. So some of these patients actually had primary shockable rhythms, possibly from myocarditis, although that was never really investigated in these particular patients. And of course, if we consider those causes of cardiac arrest in that setting, it's not surprising that the majority are non-shockable. And I think over 80% of their patients, in fact nearly 90%, I think, were asystole. So the majority, therefore, are respiratory cause, but there are a small percentage that are of cardiac cause. The outcome from those cardiac arrests are unfortunately and probably predictably very poor. And in fact, of their 136 patients in that series, 4 of those patients survived until 30 days or discharge, but only one of those, and this was a patient with a shockable rhythm, survived with a favourable neurological outcome, i.e. cerebral performance category 1 to 2. So in summary, primary respiratory cause, sadly, very poor outcomes indeed, based at least on that Chinese series.
Okay, what are the main risks associated with the resuscitation of COVID-19 patients?
Well, I think this is the really central question to the whole problem. COVID-19 is undoubtedly a highly contagious disease. Its ability to transmit is seemingly second to none compared with almost any other disease. We know that about 80% of cases, if people do get COVID-19, 80% are said to be mild, 15% moderate, but 5% are severe. And by that, we mean those requiring admission to an intensive care unit. And based on a number of series now published across the world, we're looking probably at a mortality rate of those that get into the intensive care unit that is at least 50%, if not higher. In fact, the latest updates from the UK, for those that are mechanically ventilated, mortality rates are approaching 70% plus. So it's potentially a very severe disease. We know that it affects patients, more patients with pre-existing comorbidities, but it's clearly not exclusively those individuals. And therefore, very sadly, healthcare workers are at risk of getting COVID-19. And of course, most countries of the world now have sadly reported deaths amongst healthcare workers. So, but coming to the focus on cardiopulmonary resuscitation, what is the risk in that setting? We know from observational studies, mainly from SARS, rather than, of course, from COVID-19, that there appears to be risks certainly associated with interventions such as intubation, ventilation of patients. In other words, so-called aerosol generating procedures. And we are fairly sure that there are associations with cardiopulmonary resuscitation in general, because of course that includes the use of ventilation techniques. What is unclear is whether chest compressions per se generates significant risk of generating aerosol. And just to be absolutely clear, we think the transmission routes for COVID-19 is mainly droplet spread, so rather than aerosols. And again, the definitions we've set out in the introduction section of our COVID-19 guidelines, but we think aerosols are perhaps actually a combination of very small particles and droplets. But it's a question of whether there is a risk of airborne transmission with things like chest compressions. And so it's important, therefore, that we try and match the personal protective equipment that healthcare workers are expected to use with the risk of transmission of the disease, depending on the circumstances. So I think we're fairly clear that for procedures that are thought to generate aerosol, then there should be so-called airborne precaution personal protective equipment, or PPE, and that consists of fluid-resistant gowns, gloves, of course, eye protection, and importantly, the type of mask that is used needs to really be an FFP3 mask. And by definition, such masks will filter about 99% of particles. And so that's what we are suggesting is appropriate PPE for CPR.
Okay, I understand that the protection is very important. So what is the position of ERC with regard to the safety of healthcare providers?
Well, we put safety of healthcare providers at the foremost, without any doubt at all. And there are, of course, a number of reasons for that. Number one, of course, is for the safety of that particular individual. But we must remember that if an individual healthcare worker becomes contaminated with COVID-19, we've got to consider that the symptoms of the disease take at least probably a median of 5 days to occur. We've got increasing data now to show that people are capable of transmitting COVID-19 whilst they are asymptomatic. That is clear, and this is why this disease is so dangerous. So not only is that healthcare worker at risk themselves, but they are putting other patients and other healthcare workers at risk as well, because it's going to take some days for them to develop symptoms. So we really, really must ensure that we minimize the risk of transmission of this disease to healthcare workers. That is why that we have placed so much emphasis on the use of airborne protection or airborne precaution PPE when undertaking cardiopulmonary resuscitation. And whilst we recognize we don't have strong evidence to either say that chest compressions generate aerosol or that they don't, but in the absence of clear evidence, we have erred on the side of safety, and that's why our recommendations are that even to perform chest compressions, we should be using airborne precaution PPE.
Okay, thank you very much for those clear answers, Jerry, and for making time for us.
Thank you, it's a pleasure.
Bye-bye.
Bye-bye.